So let's move on for the sake of time to another genotype that has witnessed significant advances in the therapies, ALK rearrangements, and maybe briefly we can talk about ROS if there's time. Another mutation rearrangement, 3 to 5% of all non-small cell lung cancer adenocarcinoma. It's become a crowded therapeutic space for ALK. We had crizotinib, of course, from the profile trials. We now have other drugs with ceritinib and alectinib and brigatinib and lorlatinib. Maybe we can sort out some of this in a short amount of time. Sanjay, you want to talk about, I'm going to task you with the ALEX, the ASCEND, and then the brigatinib data that has thrown a curveball with how we sequence these ALK-directed therapies.
Yeah, thank you. So this area has been moving really very quickly over a very short period of time. And each of these agents have slightly different efficacy, slightly different CNS penetration, and slightly different toxicity profiles. And I think, you know, we now have a wide variety of agents that we can currently use. So the data that we initially had in the frontline setting from the Profile 1014 data set demonstrated that crizotinib was superior to chemotherapy, and that's really become our standard of care for some time. Shortly thereafter, we had efficacy from the ASCEND studies that ceritinib was superior to chemotherapy. You know, at the time, ceritinib has very impressive CNS penetrant activity, although with a difficult toxicity profile at the standard dose 750 on a fasting diet. So since then, both the FDA and EMA have changed the label to allow 450 with food, which reduces the efficacy, reduces the side effects, but maintains the efficacy at 450 with food compared to 750 fasted. And in parallel, we then last year at ASCO had the dramatic data set from the ALEX study, which built on the previous Japanese data set, the J-ALEX study, randomizing patients up front between crizotinib, which was the standard of care at the time when the trial was open, and alectinib, demonstrating a marked superiority with a PFS in excess of 24 months with alectinib. And rapidly in parts of the world where this has become established and approved, alectinib has become the standard of care for this group of patients. Meanwhile, we have other data sets brewing, and at this World Lung Congress here, we now have presentation of the ALTA-1L data. This is using the next generation inhibitor brigatinib. So brigatinib is another highly potent CNS penetrant next generation ALK inhibitor, which has in the post-crizotinib setting perhaps one of the strongest efficacy, with a PFS of around 16 months compared to where we are with alectinib in the post-crizotinib setting of 8 months or so. So this data randomizing brigatinib versus crizotinib, which was the standard at the time, were very eagerly anticipated. And this data are really quite markedly interesting, I would suggest, demonstrating a marked superiority of brigatinib compared to crizotinib with a hazard ratio of 0.49, with the crizotinib arm performing as you would expect it to perform as the control arm, and a very nice efficacy for brigatinib with a median that hasn't been reached yet. And as you would expect, we have marked intracranial activity compared to crizotinib with a hazard ratio of less than 0.3 for PFS intracranially in patients with CNS metastases, really reinforcing the efficacy of brigatinib. Now, the key question that people are asking is, you know, which agent should I choose? And that's a difficult one to answer at this point, because the ALTA-1L data, I would suggest, represents a potentially new standard of care. But we have alectinib, which is already established in many parts of the world. Making cross-trial comparisons, I think, is very difficult, because the maturity of the data that we have for ALTA-1L is really very immature at this point, and we just need some more mature PFS data so that we can really cement in what the magnitude of the benefit is here.